So first of all, what I'm going to do is introduce each of our panels. I'm going to introduce them in the order that they're going to be speaking. The first is Nancy Naylor. Nancy is the Associate Deputy Minister of Delivery and Implementation for the Ministry of Health and Long-Term Care, who leads two large divisions. Her portfolio consists of responsibility for primary care, home care, and community care, working with the local health integration networks, health system funding reform, and the advancement of quality initiatives. I know Bob has referred Nancy on multiple occasions as one of the most capable members of the Ministry of Health team he's ever worked with, so we're really pleased to have you here today, Nancy. Secondly is Susan Fitzpatrick, who you've got to know throughout the day as my co-host of the session and the CEO of the Toronto Central Local Health Integration Network, but now we're going to hear her thoughts from the perspective of the Toronto Central LHIN, including home care as well. Our third speaker is going to be Dr. David Kaplan, who is an academic family physician practicing in low-risk obstetrics. He's currently the HQO Provincial Primary Care Lead, which is part of the hat that he's wearing while he's here today. And I've got to say, I just really enjoy his leadership and working with him at HQO. And then last but not least, the closer, as we just termed on the panel, is Dr. Joseph Lee. He is the chair of the Centre for Family Medicine Family Health Team and the site director for the McMaster University Kitchener-Waterloo Family Medicine Residency Program. But really importantly, he's also the sub-region lead for Kitchener-Waterloo, Wellesley, Wilmot, Woolwich, the KW4 sub-LHIN. And I'm going to confess, I just learned today that that's what the 4 Ws were, because it's always been the KW4. So without further ado, I'm going to turn it over to Nancy, and let's talk about a vision for the future.
Lee, thank you very much, and hi everybody. It's fantastic to see a room full of people devoted to HealthLinks and devoted all day. I also have to confess that I can never really approach a very traditional podium like this without thinking of Melissa McCarthy. I'm sure I'm not the only one who secretly wants to drive it out into the crowd. Oh, well, so let's start. Listen, the invitation to situate HealthLinks in the broader agenda is kind of irresistible for us. As you know, we've been working for the past year with the LHINs on the Patients First and the LHIN renewal and the transition that they've been leading. And but we never lost sight of HealthLinks. So grateful that this is all still out there and you're still working on it. And Lee's updates and roll-ups that came in quarterly is one of my favorite emails, as she knows, so I usually answer. So let's, if we go ahead one. Oh, is that up to me?
Sorry,
that's my job.
I should have oriented you.
There we go.
There you go. I think you pointed there.
There we go. Whoops, wait, now I have to go back. There we go. Okay, so what we set out to achieve, these should be familiar goals to a lot of you. Expanded role of LHINs, more timely access to primary care, consistent and accessible home care across the province, stronger links with public health, and better planning and more inclusive planning to address the needs of the Indigenous population and Franco-Ontarians. A year later, these are still highly relevant goals for us, and a lot of our work plan and work with the LHINs and our health system partners are focused on furthering those kind of goals. Now, we have, haven't quite got the touch here. All right, so just to look at what did happen over the past year, obviously we use the term LHIN renewal to describe our part of Patients First. I see a lot of our good partners in the audience. Hi, thank you. Obviously, the legislation covered what had to be legislated to create the changes. Creating subregions is what I would describe as a simple, powerful idea, and we are thrilled at where the LHINs are going with this, and I'm sure you're going to hear more about it from the other panelists. Renewal of LHIN governance and the management teams, expanded clinical leadership, such a great one of the most positive features. Not one that we put a lot of in the window, but what we did do as LHINs were setting out their new organization is they wanted to create a lot more space for clinical leaders to join the table, to be able to step out of their practice on a part-time basis and join, the decision-making and the discussion with the kind of dyad support and administrators to help lead the creation of subregions and help them with the new mandate. So we're really pleased at the clinical leaders that are signing up for those roles, and Joe is one of those. Thank you very much. And we're seeing some terrific names all the way across the province. You can tell patient care continuity was our major goal as we transition the CCAC staff. We also wanted that transition to be very respectful for the staff involved, but our overriding goal was to make sure that patients on home care didn't see a change or a discontinuity in their care, and I think we monitored that very closely. And I think thanks to the professionalism of the CCAC staff, that was a goal that we really achieved. Lots more patient engagement at the LHIN level and the provincial level. We now have Julie Drury as the chair of the Minister's PFAC, and we expect the remaining appointments to be announced shortly. If you haven't met her yet, she's terrific. Look for her on Twitter at Solid Footing is her Twitter handle, or you can look for Julie Drury. And I want to just talk a little bit about the LHIN mandate letter. So one of the things that is new in our world is that Crown agencies now are required to get a mandate letter from the minister who oversees them. And Minister Hoskins gave LHIN their first mandate letter. This is a few pulls from it, and you can see it on any of the LHIN websites. It's an ambitious document. It really shows the breadth of the LHIN responsibilities, and there was a lot of detail around strengthening specific segments of the healthcare system, hospitals, primary care, home care, mental health, digital health, and a fair amount of direction around the patient experience, strengthening transitions, and strengthening provider partnerships. So big agenda, and one of the things that we have worked with the LHINs over the summer on is to translate that into very specific projects, tables, who does what, so that we can translate that very aspirational mandate letter into concrete progress in a lot of areas. But, I think we all know that we didn't embark on patients first just to strengthen the health system segment by segment. And really what we are looking for is integrated care in the long run. So what the LHINs really have taken to heart, and this is really where the subregion concept comes in, is how do you make integrated care happen across the different segments and provider communities. So I have an example where I borrowed from the Southwest LHIN, Mike Barrett. Anybody here from the Southwest LHIN? Hi. Over here too, right on. So you'll probably recognize this. These slides are a little old, and I think Mike's got a new version coming, but he said we could borrow them. But it's a great illustration, and I think that any of the LHINs have this story to tell, and you may hear some of it. But that as a big LHIN, it's bigger than some provinces, almost 1 million people, but they identified 5 different subregions. I just want to show, and this will not be a surprise to anyone in this room, but this is their provider community, right? 19 different hospitals. What always stands out to me is that Southwest is a LHIN that has 78 long-term care homes, over 30 agencies providing mental health and addiction. So this is a lot in terms of a provider network. So where do you start? And I think the subregion concept, to their credit, Southwest LHIN has been working with providers and patients in each of the subregion to really create what they're calling integration tables, which will roll up into the Patients First mandated Patient and Family Advisory Committee, and a renewal committee that also has a substantial representation from patients, but that each of those subregions will have their own integration table that will be able to look at priorities in that particular subregion. So, the type of representation they're looking for at those integration tables really does come from across the provider community, but it does give them an opportunity to say what are the local priorities, what do we want to work on together, and potentially an opportunity to discuss patients that illustrate where there's gaps in care or gaps in capacity. So I am hoping you guys are involved in that. Now, what does this remind you of? I think for most people in this room, it reminds you of HealthLinks, right? And I can't tell you how many times in the last year and a half that I have been struck by the fact that nothing in Patients First would be possible without the groundwork of HealthLinks. If you look at the sub-region map that makes sense to us, that is in place now, that is reflecting to a very large degree the HealthLinks boundaries or experience from HealthLinks. In some cases, LHINs felt they needed, to break that down smaller. Some cases, they wanted to group up into a larger geography. I think LHINs reached out to some of the same system leaders and thought leaders to bring this change about. And I think HealthLinks is going to be central going forward. So I'm just going to close with a diagram that's familiar to you, but I think this diagram will evolve. But certainly our plans for supporting the LHINs and what we know of the LHINs planning still relies on HealthLinks as a central strategy and capacity in every subregion to make sure that complex patients are identified, coordinated care plans are identified, connections with primary care are made, and so I am going to stop there, but I want to say thank you so much for the groundwork, for the inspiration, and for what we are going to call on you and hope you'll work with us on going forward. Thank you.
I'm going to talk about two objectives I was asked to reflect on. One is how do we take the HealthLinks approach and start to move into subregions. And then I'm going to focus on two areas or two approaches that I think will accelerate that work. I wanted to start with just what does the subregion look like, and this is a design we've had, I think, out in our collaborative sessions for the last year or so. And I think Dr. Bell today talked about what is at the core of the subregion. And we know the main areas that we're trying to create in the subregion are primary care and home and community. So on the one side, you see primary care, and you see all the models. We've got FOs, FINs, FITs, CHCs. We also have other community clinics, IHFs, diagnostics. We've got solo practitioners. So we've got a lot of primary care activity that is largely unorganized. So I think, job one in primary care, and in Arlen, Jocelyn, and Charles and the sub-region leads are trying to really effectively create a virtual network so we can take these many different primary care providers and bring them together in some kind of network. Then the next area is home and community-based care. And the LHIN role has changed there. We have a direct service role, but we also have lots of community care and community mental health providers. In our LHIN, I think we have about 150 different organizations. So again, we're trying to organize home and community care from within the LHIN and then within our community. And we also look at the hospital. I mean, after all, people are going into the hospital emergency, sometimes with very low acuity issues, and they could be there for acute short stays. So how do you get better organized in those dimensions of care? So we've identified 8 areas that we think are important to create a subregion. The first is, and they're in no real order, but is to build partnerships to advance social determinants of health. And people have reflected on that today. We're very actively working with the City of Toronto. We know if we really want to deal with the health issues in the Toronto Central LHIN or any LHIN, we can't do it solely from the health budget. The second is to leverage our HealthLink partnership. That is a critical component to a sub-region model. We need to have excellent ways of taking care of complex patients. The third is looking at a model for care coordination and navigation. And I'm sure many of you are aware of the many initiatives underway. There's been a provincial table led by Nancy and Phil and her team trying to get a view on what is the care coordination model and what is the model we would be implementing at the sub-regions. Fourth, aligning home and community care as one integrated system. So how do we take the resources within the LHIN and within the community and essentially have one system? We're talking a lot about one number to call at a sub-region level. There's a lot of work required to get there. Fifth, making sure we have strong patient and caregiver involvement. We have a citizens panel. We've had it for about a year and a half. The province has now asked all LHINs to have patient and family advisory committees. We'll be refreshing ours. And I think one of the speakers today talked about co-design and how we really have to work at how do we design the system with our citizens and caregivers and patients. That's not easy work, but it's very, very important to do. Sixth, to deepen the understanding of the community's health needs. And this is really taking a population approach to looking at the people that live in our communities. When we first started talking to primary care physicians, they looked at their practices, who is rostered to them. We looked at who are their rostered patients. They can come from all over the province. So then we would say, well, what do you know about the patients living outside your door? So we've tried to say, if you're working and living in a community, then we're looking at those patients, those clients, and trying to have a neighborhood view of what those communities need. Seventh, we're looking at building a strong community-based primary care network. And I think we do that through the establishment of strong interprofessional teams. I think I'm often asked, how can we involve physicians in integrated models of care? I think it's very easy. We look at team-based care. We've been experimenting with models in the Toronto Central LHIN that I think are working quite well. One would be access to interprofessional teams at community health centers. And finally, sharing information across sectors. And we heard a lot about that from Ben King today. So we know we need the digital supports to make the model come alive. I'm not going to spend too much time on this slide other than to say the sub-region model is for one set of services, and especially in a complex LHIN like Toronto Central, we have tertiary care hospitals that take referrals from across the province. The sub-regions are part of the picture, and what we talk about is having good local services and an ability to transfer the client or the patient back and forth through regional services and provincial services. So that is the system we're trying to establish. So the two areas that I think really go towards supporting a sub-region planning approach. First is a focus on quality improvement, and I put that in there for Lee. Yes, Lee. I've got the message. Do you think some of the most successful discussions we've had at the sub-region is when we engage on quality improvement? And that shouldn't be a surprise. I worked in a ministry with Deb Matthews, and she always wanted to engage on excellent care, quality improvement. So I think it's something that people agree with, and it's easy to bring people together when you're talking about improving quality of care. So we took a health equity approach. We identified hot spots. We would like to go further than that, but we looked at 74 neighborhoods, and we identified areas for improvement. So out of those, 5 areas were selected in the Toronto area. Moss Park is one of those. People that have been following us, so I see them on the 1 minute, will know that there's a big opioid issue there. And we've formed quality improvement teams, and they're going through the ideas training. So that has been a fantastic initiative. So in our sub-region collaboratives, the health service providers will sign on to one quality improvement plan for that service area. Secondly is a population approach. So if you look at LHINs, our LHIN is about 1.2 million. Our sub-regions are between 200 and 300,000. So we really need to get into this hyper-local planning where we're looking at smaller neighborhoods that might be 25 or 30,000, 25 or 30,000 people. And we can look at them specifically. And I think the more I spend time in the LHIN and I look at neighborhood approaches, I really think, it has to be customized. You could try to design a program for your whole LHIN, and it would fail if you don't understand how it's going to apply in these many, many diverse communities. So that is where I think the big changes can occur in terms of the sub-region development and planning. And I'm going to skip over that and hand it over to David.
To planning and care. And before I trained in medicine, about 20 odd years ago, I did my master's work in bioethics. And one of the things that I remember very clearly having a lot of difficulty understanding was what Beauchamp and Childress called justice, one of the 4 principles of family medicine, if people have heard of those before. And I think through a lot of the work that we've done that I did when I was a primary care lead in one of the LHINs around health links, it really taught me to understand that principle of justice actually more as a principle of equity. And I think that focusing on building equity into the planning and care can be accomplished very strategically by implementing a lot of the quality standards that we're working on to help transform the health system here in Ontario. And just so everybody knows and everybody's on the same page, equity is considered the absence of avoidable or remediable differences among groups of people, avoiding inequality with social determinants of health, and accessing resources. And I hope this goes forward. The one lens of equity that I'm going to talk about today is just income, and I'm going to give a very specific example near the end of my remarks. This is a report that Health Quality Ontario produced. It's called it was actually just called Income and Health, and it really documents how income affects health in Ontario. So for instance, among the poorest people in Ontario, compared to the richest, there is almost a doubling of patients over the age of 12 who report having multiple chronic conditions, pretty similar to probably some of the patients we look after in health links. When we look at things like cancer screening, people who are in wealthier areas of the province have higher rates of colon cancer screening. And one specific example that's going to be germane a little later is insurance, not just medication insurance, but insurance for other allied healthcare services. And so you can see there's quite a discrepancy among people in the province, with people in the highest income quintile almost having a universal coverage or access to allied health services through supplemental insurance. So really, I remember being a family doctor and starting on the Health Links journey and thinking about, this quote that Bill Murray, that people have seen Groundhog Day, is like keeps on happening already, and there's nothing I can do about it, right? Like I have these patients who come into the office and I feel I really don't have any ability to influence their health outcomes. But I think if we understand health equity as all people being able to reach their full health potential, it really behooves us to understand that means that some people will need more help than others. And I think that the HealthLink experience has taught us that it's not the equal dividing of resources so that everybody gets an equal piece of the pie. Rather, it's an approach whereby factors like income and race and language and geographic location and disability don't impede improved health. And I just want to highlight, just before I go into this specific example today, which is going to be around pain management, the principles of family medicine, specifically the fourth principle of family medicine, which is that the family physician, and in this case I consider probably all primary care providers, includes pediatricians and nurse practitioners and everybody else, is really a resource to a defined practice population. And what does that mean? Well, it means a number of things. It means that we need to look at our practices as populations at risk. We need to look after them within the geography that we work whether or not they come into the office or they don't come into the office. And that is a fundamental difference when we think about trying to apply standards to people who we traditionally interact with on a transactional basis when they come into the clinic. We have an ability to plan, to plan and to implement policies that will enhance their health, to advocate public policy that promotes health as clinicians. And I think the last thing is that we learn from this principle of family medicine is that as clinicians we have a responsibility for wise stewardship of scarce resources. So I want to give you, I'm not going to name this is only part of a sub-region where I'm going to show you some data from, and I'm not going to name the sub-region. So what's wonderful about the City of Toronto, and this one happens to not be in Toronto Central Inn, but in Central Inn where I practice, is that the City of Toronto has created a lot of data around the socio-determinants of health. And so this is part of a sub-region. It's not a whole sub-region, and this shows you the top 10 non-official mother tongue languages spoken in the sub-region. So you can see quite an eclectic mix of people, pretty similar. In Toronto, where I practice in North York, about 50% of the people don't speak English as a first language at home. And then if we look at income in the same area, you can see quite a discrepancy of income in this third of a sub-region. So never mind just a whole sub-region, just a third of a sub-region. And the reason I bring that up is because I want to focus us on one of the quality standards that's been available for the last month in draft on the Health Quality Ontario website. And this is around opioid prescribing for chronic pain. And in the quality standards, we have aspirational guides or aspirational statements for our healthcare system. And specifically with this one, there's one, I hope you can see it in big, yeah, you can see it right at the bottom there. And it says alternatives to opioid medications. This is written actually for patients. And it says that you should have access to a combination of physical therapies, psychological therapies, and non-opioid medications. They're the first choice for treating chronic pain. Your healthcare professional should offer you these therapies before offering opioids. And you can imagine for people living in this part of this sub-region, they may not have access because they don't have coverage to access those resources. And I think, when we talk about transformation of a health system, we have to realize that we're going to shed light on areas of gaps in care. And that's going to be transformational because we're going to have to figure out how to bridge those gaps. And one example of this has already been in the depression quality standard that we had released at Health Quality Ontario, which talked about offering cognitive behavioral therapy to patients with major depression. And following that release of the quality standard, the minister did make an announcement around increased investments in being able to offer group cognitive behavioral therapy to people in the province. So I just wanted to highlight how just one specific lens of equity, and that is income, can have an impact on just a small piece of one clinical problem that you could adopt in a sub-region as maybe an issue. And I'm looking forward to questions later. So thank you.
Yeah, hi, I'm Joe Lee. I'm a family doc. I was glad when David mentioned Ian McWhinney's 4 principles of family medicine. So I wear many hats, but really at the heart, I'm a family doc, which is actually why I'm very comfortably being very casual and like the most shabbily dressed guy here. So, and Lee did a great job of recognizing what KW4 is. And I come from that area, and I'm going to just speak about our little area's evolution in primary care. KW4, you might have heard of at least the KW, which is Kitchener-Waterloo, and 3 surrounding townships, which all start with W. If you don't know, think of Oktoberfest, like sausages and beer. Or if you have a smartphone, Mike Lazaridis from our area invented it for the world. So our area is about 390,000, which is about half of our LHIN's population. Our LHIN, which is Waterloo Wellington, has 4 such sub-regions. And I suppose typical for Ontario, our primary care in our particular sub-region, KW4, is a heterogeneous landscape. There are 2 family health teams, including my own, which is an academic family health team. There's a couple of CHCs, and then there's, well, people would say a dog's breakfast of other stuff, like foes and figs and so on and so forth. And it is really a challenge and an opportunity in primary care. I give credit to the folks in Waterloo Wellington that there has been a very intentional, purposeful lens of using primary care, and really the patient center medical home, which Bob Bell spoke about earlier, and our Ontario College of Family Physicians, Canadian College, certainly endorses that model. And I think a lot of the history of what's happened locally has been reflected in that, trying to make people at the center of this, the people that we serve. Our own history goes back many years about how to engage primary care into the local system. I give credit to the 2 regional hospital CEOs who reached out to primary care. They didn't really know how to engage primary care at all, but they knew that there were the 2 FITs that had just started and the CHCs, so they thought, well, if nobody else, we can reach out to those guys. And so we worked on a number of things. This is pre-Health Link, on simple things like, getting those admission notes and discharge reports and stuff like that. And I'm happy to say after like 10 years, we're back at least equal to how it was 29 years ago when I first started practice, of actually getting notified about patients coming in and leaving the hospital. So that's great. We've made a lot of progress in that. Many other things too, though. Of course, I'm joking. It's been very good to have this pre-existing relationship, because at the end of the day, we're talking about systems level, but it's people and their relationships. This group morphed regionally into really our Health Link steering committee. We engaged a wider stakeholder base to when it formerly became Health Links, but that primary care hospital linkage and CCAC formed, I think you could say, the base for our regional Health Link strategy. And our own feeling is that this has all been evolutionary, and the turn into these sub-regions, or whatever you want to call them, I think is a natural evolution, again, from what's been happening. I think Nancy had a much better graphic than this, so I'm going to skip that, because it really is about patients and families being at the center of things. And just to speak about our own sub-region, some examples. And I heard before, how do you get primary care involved in it? Well, I would say a lot of things are naturally occurring, and you really want to listen. I think where the success that we've had, if we've had any, has been listening to people and what their needs are. And so people say, well, there probably should be some sort of platforms, and so things like having e-health underpinning things is certainly important. And so regionally, we have an e-health center of excellence. Many of you in probably about 8 of the LHINs would hear about things like systems coordinated access, which would be just big words to say, like making the referral system to specialists simpler, easier for everybody, using pretty simple technology. And actually, it isn't the technology. It's clinicians sitting down with people like orthopedic surgeons to say, hey, let's do things a little easier and better for the family docs and the nurse practitioners and you. And that's where you marry technology with people and changing behavior. We've had a great deal of support from the LHIN with regards to the Health Links initiatives, driving things like our community ward, which is is a home-based or in-home interdisciplinary team which is open to the region for those extremely complex persons who need that extra wraparound care. That's been a huge success. We have very good measures on that. And we've also driven through the HealthLink project and our program really a number of innovations which were based in KW, many of which many of you here in this room might have heard of. So I know some of you might, actually I saw Joe Connolly had a little nod to memory clinic and primary care-based memory clinics in Ontario, actually started in KW by, well, my wife Linda, so I'm better known as Linda's husband. So there are 107 such clinics in Ontario. Most of them are in family health teams and so on. But in KW, we're listening to the people there because there's an inequity. You know, those who are in family health teams could get service and those not in family health teams could not. So this certainly does not seem fair and equitable. So we worked very hard with the LHIN, with the hospitals, with regional partners, the FITs and so on, to actually extend and expand it to the whole population. So, and this was driven by people and their stories and how it does not seem fair to have those things. In a very similar way, people who have severe physical challenges, who can't get their pap smears, can't get their immunizations. We developed a regional mobility clinic model that some of you here in the province would also understand. We have a provincial training program to try and help develop. Again, this is about equity. People with severe physical challenges, they're that little kid who can't see over the fence, and we're not trying to do things that are super different. It's just level the playing field for these folks. In KW, we've also had a huge influx of Syrian refugees. I think behind only Toronto, Montreal, and Vancouver. I think we're the fourth highest region for these refugees. And so we've had to have a local strategy of how to help these folks be welcome in our region. We're in active talks, discussion with multiple stakeholders about well, again, what the people are saying. Mental health and addictions, as many people have said. Also refugee health in our region is a big deal as well. In a governance sense, our HealthLink steering committee has been engaged in a number of discussions, and this is a work in progress of how do we turn the HealthLink steering committee and its governance into really a group that is wider again and continues to build a local care community. So we certainly don't have all the answers. There's miles to go. We're very excited, though, to collaborate and listen to other people and how we do all this together. So thank you very much.